Good evening all. I will be presenting my paper on usefulness of SDOCT parameters of peripapillary RNFL macular GCL in assessing the clinical course of idiopathic intracranial hypertension. As we all know, idiopathic intracranial hypertension is raised intracranial pressure in the absence of an identifiable cause. It is diagnosed by modified Dandy's criteria. It is more common in women of reproductive age with a BMI of more than 30 kg per meter square, which is known as typical IIH, and the diagnosis is often delayed as the general knowledge regarding this condition is limited and doctors from multiple specialties are consulted. So what is the role of an ophthalmologist? IIH usually presents with severe headache, visual disturbances and bilateral papilledema. An estimated rate of 10 to 24% progress to severe and permanent visual impairment. Visual loss can occur any time along the course of the disease. So it is the ophthalmologist who diagnose and even follow up the patient, and neurologists take a feedback from us in deciding the further course of treatment. So what is the role of OCT in IIH? It captures optic nerve head swelling that characterizes papilledema and retinal nerve fiber layer changes associated with acute and chronic changes in intracranial pressure. So whenever there is reduction in RNFL thickness, there comes the dilemma, whether it could be an improvement or there is an axonal loss. Here comes the role of macular GCL. A preserved GCL in the presence of reduced RNFL thickness offers reassurance that optic nerve is not losing axons at an abnormal rate. So the aim of my study is to assess the clinical correlation of SDOCT parameters of peripapillary RNFL, macular GCL and visual field changes associated with the clinical course of IIH. So it was a clinical observational study which was conducted between the time period of September 2020 to October 2021. 4 patients diagnosed with IIH according to modified Dandy's criteria were included, and they were followed up depending on the clinical course. Ethics committee clearance was obtained and written informed consent was obtained from the participants. Patients with any reported previous retinal, macular and optic nerve diseases were excluded from the study. So data collected include demographic data, presenting complaints, complete ophthalmological examination including color vision, pupil and dilated fundus examination, visual field examination using Humphrey's Field Analyzer 30-2 program and Heidelberg Spectralis OCT for evaluation of peripapillary RNFL and macular GCL. So first case was of a 35-year-old female who presented with headache for 4 months duration. On examination, her best corrected visual acuity was 6.6 and 6 in both eyes, and she was already on tab acetazolamide 250 mg twice daily. On examination, there was bilateral papilledema and HFE shows some peripheral defects in both eye, and OCT RNFL showed increased thickness in both eye with preservation of macular GCL. Based on her OCT findings, the tab acetazolamide dosage was high, and on her review, there was symptomatic improvement which is reflected well in her OCT and visual field analysis. And on review, the papilledema resolved and HFA shows clearing of defects in both eyes, and OCT showed reduced RNFL thickness in both eye with preservation of macular GCL. So second case was of a 25-year-old female who presented with headache for 4 months duration. On examination, her best corrected visual acuity in the right eye was 6.6 and 6, and left eye it was 6.9 and 6, and she was already on tab acetazolamide 250 mg thrice daily. And on examination, there was asymmetric papilledema which was more in the left eye, and HFE shows enlarged blind spot with central scotoma in the left eye, and OCT RNFL showed increased thickness in the left eye more than right eye, and there was macular GCL thinning in the left eye. And dose of tab acetazolamide was hiked to 4 times a day, and on review after 3 weeks, there was papilledema persisting, and HFE shows enlarged blind spot with central scotoma in the left eye, and OCT RNFL thickness further increased in the left eye with macular GCL thinning in the left eye. So she was referred for surgical options in view of her progressing to fulminant IIH. So case 3 was a 30-year-old female who presented with headache for 6 months duration, and on examination her best corrected visual acuity was 6.6 and 6 in both eyes, and she was already on tab acetazolamide 250 mg thrice daily, and she was advised from elsewhere to undergo a shunt procedure. However, on examination her fundus examination was within normal limit, HFA, OCT and RNFL and GCL was all within normal limits, and on her review after 1 month, again the fundus was normal, HFA was within normal limit, OCT, RNFL and macular GCL was preserved. So she was maintained on medical therapy. So case 4 was a 29-year-old female doctor who was a non-case of IIH, status post-decoperitoneal shunt, who was still having headache. On examination, her best corrected visual acuity in the right eye was 6.6 and left eye it was 6.9 with RAPD in the left eye. And on examination, there was pale disc in both eyes, and right eye shows some peripheral field constriction, and left eye shows inferior altitudinal defect, and OCT shows RNFL thickening, which was more in the left eye, and thinning of macular GCL in both eyes, and in the left eye, it was more thin in the superior quadrant, which correlated well with the visual field changes of inferior altitudinal defect. So she was referred to neurologist, and lumbar puncture was done, which showed a CSF opening pressure of 30 cm of water, and a shunt malpositioning was noted. So she underwent a reshunt procedure, and on review, she was symptomatically much better, with both eyes showing pale disc, and right eye shows a clearing of defects in HFA, with left eye showing reduction in her inferior defect, and OCT RNFL thickening reduced, and there was thinning of macular GCL in both eyes. So these cases points out the emerging usefulness of OCT parameters for identification and monitoring of papilledema over time. And OCT is recommended for quantification of papilledema, and it has been demonstrated to be a valuable additional tool. Serial OCTs can be taken to know the cause of the disease, and treatment modalities can be altered depending upon the same. So in an article published in 2020 by David Morono Ajono et al. On updates on imaging in IIH, it was stated that rapidly improving quality of OCT imaging may offer a possibility to reduce number of lumbar punctures for follow-up. So the take-home message is OCT is a promising imaging technique which can aid as a valuable tool in diagnosing and follow-upping the disease. And macular GCL may aid in detection of optic nerve injury earlier than RNFL changes and correlates better with visual field changes than peripapillary RNFL. Thank you. These are my references.
Very nice presentation. I have a couple of questions.
Yes, sir.
The first question is, what is your exclusion criteria that you have taken in your study?
Any previous retinal and macular pathologies or optic nerve diseases like glaucoma, which can affect the OCT, like RNFL thickness and all.
But what about patients who are already, because you said who are in the age-bearing group, right?
Sir?
The ladies were taken over in the
yes,
age-bearing group. So did you rule out any patients who are on OCPs or any hormone replacement treatment?
No, sir.
You have done that. Did you also look at the correlation of refractive error in these patients? Because all these patients had papilledema, right?
Yes, sir.
So was hyperopia excluded from these
no,
patients?
Sir, no.
Okay. The second question is, based on your OCT findings, on all the cases that you have projected, how did you decide between a medical and a surgical approach in concurrence with a neurologist?
Depending on the progression, like if the patient is having severe symptoms, and depending on the progression, like the rate of progression, if the RNFL is showing a rapid increase in thickness, and if there is any GCL thinning, and in the second case there was asymmetric papilledema, so and it was affecting the vision of the patient. So we referred in if the patient.
In one of your cases there's a progression,
Yes,
but you have still advised for medical treatment. That's the reason why I asked.
No, sir. In the second case, the patient was referred for surgical management in view of fulminant eye.
Which you deferred and you started medical management, right? There's one of the cases.
That was third case, which was referred from elsewhere for surgical management, but everything was normal, so maintained on medical therapy.